We've tried to be as open as we can. All of the numbers that I know you have, we'll be presenting again next week. We've talked about ages of people. We've talked about the community impacts of this. We've talked about where outbreaks are. I will say, and I'll say it, we've said it from the beginning, there was a period of time where there were many people who had returned from travel where we said we didn't have the capacity to test, and we didn't want people who were ill to leave their home to have to go to a facility to be tested and various things like that. So we do know that there are more people who have had this illness in the province than the people who test positive. And, you know, I talk about this every day, that we've had 11 new people who have tested positive. We also know that that sometimes we don't need to test people. For example, in a family unit, if somebody is sick with this and has tested positive, and somebody else in the family gets compatible symptoms, there may be reasons why they don't want to go in to get a test, and they have a mild illness and they're isolated at home, and we're following them. And we call those epidemiologically linked cases, and I've talked about this before. So yes, there is more illness out there that we have not had a person test positive for. And one of the reasons why we have been actively working on validating a serology test, because that's a good way of helping us understand how many people, you know, what percentage of the community of our population has actually been affected by this. And we also know, as we've learned from this virus, that people can have mild enough illness that they may not even recognize it in themselves. So we are starting our serology testing strategy. We've been, the lab has been very busy, the VCCDC lab, working with the public health labs across the country to find a test that has enough sensitivity and specificity, which means it truly can tell if you have the illness, if you have the antibodies, and it can truly tell when you don't have the antibodies. And the testing on that, the validation part has started, so we're hopeful that we'll be able to do some broad testing in the community very soon. Part of our survey is the option to be part of serology testing, and I know at least 200,000 of the 300,000 people who've taken the survey so far have ticked that box. So we will have lots of people who we can test when we have a good serology test.
I was hesitant to answer questions on polling, but I would say this, that we have national polls. There's a BC subset of those polls, and it'd be very interesting to know what N equals in that case. But what we've tried to do in this case, systematically, we're the first province to provide and say what our modeling was, which provided everybody with an understanding, I think, of what we needed to do together. And then we did it again, and we've done it again, and we're going to provide again more modeling next week to let everybody in BC see what we see. That's why there's been 18 weeks since I think our first briefing, which should become daily briefings or virtually daily briefings to the public, either written or here from Dr. Henry or Dr. Henry and myself. So I think all we can do is ensure that people have access to that information. But the results that I like to see are the ones that we've seen, which is a decline in hospitalizations, a decline in people in critical care, and a decline in the active cases. And all of those are the things that we've seen, and those are all good things. That shouldn't have us let up or be any less committed to this cause together. But I think those are the things we like to see when British Columbians were asked to contribute to this cause. They contributed, and I'm so proud of them, and I think that reflects better than some subset of some national poll might.